Our next speaker is Professor Erik Stålberg from Uppsala, Sweden. He has developed a number of EMG methods, such as single fiber EMG, macro EMG, scanning EMG, and methods for quantitation of conventional EMG. He has studied the microphysiology in normal and diseased muscle. He's also our very good friend and a supporter of the Ljubljana Institute from the early beginnings of the Institute. He's also a corresponding member of the Slovenian Academy of Sciences and Arts. I'm really glad that we can have him again in Ljubljana, although this time virtually, and he will talk about quantification of EMG and neurography. Erik, please.
Lars, thank you very much for invitation. I have made a video about the summary of the standards that we wrote for IFCN last summer. I will be happy to have some questions after the video. So we start the video right away. The article from 2019 on standards for quantification of EMG and neurography is a multi-authored manuscript in collaboration with IFCN. I'm going to make some comments on this article without going over all the details. Methods for EMG analysis are well known to all of you, and here is the topics that were covered in this manuscript, namely needle EMG and the different parameters on spontaneous activity, motor unit analysis, and so on. And here is how we quantitate the different features that we are recording. Spontaneous activity is not quantitated in numbers, but it's a visual scoring. Motor unit analysis can be quantitative either manually with cursor settings or automatic with software inbuilt in modern machines. Recruitment pattern has been often visually assessed, but it is an increasing interest in getting such a software for automatic analysis. Interference pattern analysis has been automatic for quite a while. There is a new interest in surface EMG, and I will discuss a few of these features. Let's start with spontaneous activity. Here are examples of complex repetitive discharges, myotonic discharges, myochymic discharges, and neuromyotonic discharges. And here is some of the definitions. The insertional activity is seen just when we insert the needle electrode, but it has disappeared within 300 milliseconds. If it continues for a longer time, and particularly without new electrode movements, it is abnormal if it is recorded outside the end plate zone. Insertional activity can also be decreased. Fasciculation potentials, also in motor neuron disease, are usually generated in the axon, and they also produce F responses, for example. CRD is the hepatic transmission between hyperexcitable muscle fibers, as seen both in myopathy and chronic neurogenic disorders, so that is an unspecific finding. The myotonic discharges show a waxing and waning phenomenon of individual muscle fibers. The myochymic discharges are one or many motor units that are activated semi-rhythmically with frequencies of 2 to 10 Hertz. It starts also in the nerve. Neuromytonic discharges are of different kinds, the double discharges, triple discharges, and so on. And the very typical is the high frequency discharges of frequency of 150 to 300 Hertz, so-called pings. cramp discharge that looks like interference pattern. A few words about the motor unit potential. The central spike, the amplitude is a little higher in monopolar than in concentric, but the duration is the same. Here is a typical display from equipment with software for motor unit analysis. This display is very similar for the different EMG equipment. This is an overview of the firing pattern. Here are individual triggered or extracted motor unit potentials, and here is the averaged signal. And this is a group of 20 different averaged signals. And some table of the values, and here's a plot of duration and amplitude with reference values for individual data and for mean values. For the interference pattern, we have many different methods, and I will only mention this one, the turns amplitude analysis, where we plot the turns on the x-axis and the amplitude on the y-axis. Number of turns per second and amplitude between turns. Here is the 95% confidence limits, and the individual dots are recordings from 250 milliseconds epochs at different places, 20 different places in the muscle. This is the normal pattern. This is the low amplitude, often with high number of turns not seen here in myopathy, and the low number of turns and increased amplitude in a number of recording sites in a neurogenic condition. And here is a situation where the motor unit analysis and the interference pattern analysis showed different results. The motor unit potential analysis all showed values within normal limits, while the interference pattern, because of the polyphasicity and because of the many low amplitude turns, showed low amplitude of each individual turn and many turns, increased number of turns. So here you see an example where we need both types of analysis to be relatively sure about the condition. Recruitment parameters has usually been assessed visually. Quantitation concerns the recruitment frequency, which is the rate of firing of the first active motor unit potential when the second one begins firing. And the other is the recruitment ratio, which is the firing rate of the most rapidly discharging motor unit divided by number of active motor units at this moment. Surface EMG is attracting more and more interest over the years, and here is one such example for quantitation, namely to look at whether the activity is evenly distributed along the timeline, or if it is grouped in some way, indicating loss of motor units and reinnervation. Here is a normal situation, and here is a neurogenic where we have large motor unit potentials, and then there is nothing and nothing, and then is a large motor unit potential again. And then the quantitation concerns how the activity is distributed, and an index is calculated. And here's an example where we have neurogenic and myopathic. This is regular scale and this is log scale. If we look at the log scale, we have the area of the signal here and the clustering index here. And you see how the neurogenic have this distribution of black dots compared to the reference material. And here is in myopathy how the reference material is here, and the myogenic recordings are on this lower part of the cluster index section. Another surface recording is with high density EMG that has been developed long ago and successfully used to look at individual motor units and their distribution in the muscle. This is 256 different electrodes closely packed and recording from the masseter muscle. And here you see, after extraction of motor unit potentials, the distribution of one motor unit along the y and x axis. This is used in research. It has not reached the laboratory for diagnosis of myopathy or neuropathy. Then we have neurography, and the special technical considerations is the electrode type, namely size, and also the position of the two recording poles. The interelectrode distance, which is particularly important in sensory recordings. Temperature control, muscle length is also important. Here I just want to show the effect of the so-called reference electrode E2 in the motor conduction studies. Here is a conventional study of the tibial nerve. This is distal stimulation, proximal stimulation, and here is between abductor hallucis and big toe, the conventional signal. But when we record from just the reference, from big toe versus a remote reference, for example the other foot, then we get a very large signal. And when we record from exclusively abductor hallucis, we get a small signal, and this minus this will produce this signal. So the signal that we usually record is, in this case, mainly volume conducted signal to the reference electrode generated in all the small foot muscles. And for the proximal stimulation, we have usually a lower amplitude, which is not due to inexcitability of the nerve in the fossa popliteal, but dispersion of signals in the foot. We see that when we do just the C2 recording, we have an extra early phase, and this is far field potentials from the leg muscles, tibial innervated leg muscles, and luckily the same signal is seen with the E1 electrode. And when we take E1 minus E2, this part will disappear and only produce a small signal. There are similar situations for all the recordings of the CMAP. In a normal motor conduction study, we always do the F response, and I consider F response to be really a part of the conduction over long distance. Here we make 20 stimuli. In other laboratories 10 stimuli is the standard, but in any case it is good to look at this and superimpose, and by superimposition it is easier to see the small A waves that are occurring at a constant position along the sweep, either between the CMAP and the F response, within the F response, or even after the F response. The E1 and E2 poles for sensory recordings is really crucial. If you use a ring electrode, it's very important to have a constant distance between the rings on the finger. We have to measure and fix that for a standard within your laboratory. Here's a situation where we have changed the position of the ring electrodes in a simulation study. Here the electrodes are very close, and the time between the signals from one and the other of the poles is just 0.1 millisecond. And if we separate them a little more, the amplitude is higher, and then it comes a maximum. And when they are separated even more, then the response becomes polyphasic. You must have standardized distance between E1 and E2 and have the same distance as has been used when you create the reference material. In this publication, it was also a small section about the definition of pathology, but nothing new really is added here. And then we come to repetitive nerve stimulation. The normal is that we give up to, for example, 10 stimuli with a frequency of 3 Hertz. At least between 2 and 5 it should be low frequency. In myasthenia gravis we may have normal or low amplitude depending on the condition of the motor end plates, and a decrementing response with maximum decrement around the 4th or 5th signal. Classically the 1-4 amplitude or area difference is counted, and then we have a slight facilitation giving this saddle-shaped or U-shaped signal. And the scheme in myasthenia can be the following. We have a short activation scheme just to see facilitation. So 10 Hertz, we see the decrement here, 10 seconds of maximal activation, and then we see an increased amplitude, which is facilitation, and also less of decrement here than here, maybe even no decrement at all. Facilitation is both these phenomena, both increase in amplitude and decrease in decrement. But for the diagnosis of myasthenia, we use a longer activation period. Here is at rest, and then 60 seconds of activation. Then we have no chance to see facilitation, but we come into the exhaustion phase. Here we may see already a little more of decrement than before, and after 1 minute it's even more pronounced, and after 3 minutes it's returning back to normal. And for Lambert-Eaton myasthenia, we have the initial low amplitude and decrement. 10 seconds is the optimal activation, and then a facilitation that is more than 60%, and then it returns to lower and lower amplitudes. The paper also includes a section on MUNI methods, motor unit number estimation methods, which are used in neuromuscular diagnostic workup and mainly successful in neurogenic conditions, where they are also used to monitor changes over time. There are many methods that have been developed, and I will only show examples of printout of 2 of them, namely Munix, which is surface recording of the interference pattern during increasing strength, one time and another time. This is one patient. And from the information from the CMAP and from the interference pattern, it's possible to get an information about the number of motor units, or rather an index correlated to number of motor units. This method is implemented in some of the recent EMG equipment. And here is another method called M-scan, more recently developed, where there is a plot of stimulus intensity and CMAP amplitude, and this is from a healthy subject, and this is from a patient with a motor neuron disease, where there are steps in the curve indicating loss of motor units. with sophisticated signal analysis, it's possible to calculate the number of steps in a more precise manner. Pediatric neurophysiology is quite another ball game. It differs regarding the way you behave with the patient, with the parents, and with equipment and the environment. But the practical things also is the electrodes you use. Large electrodes give larger signals, but if you take small electrodes, then you get higher amplitudes, because small electrodes give higher amplitude. And if we use small electrodes, fixed bar electrodes for sensory recording, we may use so-called pediatric electrodes, and they have short inter-electrode distance and therefore produce lower amplitude just because of technical reasons. So that must be taken into consideration. And the reference values must definitely be obtained exactly with the same technique as you use in routine. And finally, the reference limits and the development of reference values for your own laboratory, or import reference values from literature. It is really crucial to have reference values for any quantitation. It's important to use the same methods in routine as has been used for the collection of reference values. And when we collect the reference values, we try to include in the multivariate analysis the parameters that we think have importance. Then we define statistically the 95 or 99 confidence limits and get an algorithm that looks like this. The age is a factor, height is a factor, and in this situation temperature was a factor. And then we can tell how many standard deviations away from expected value this is, and that is called z-score, which is a number of standard deviations measured. The way how we obtain reference values is either from large databases of healthy subjects, and this is more and more difficult to obtain today for different reasons. But another and new way is to use a statistical extraction of data from a mixed material where we have patient values, and some of the patient values are within normal limits, and that can be defined, and there are a couple of publications. One is called eNorm and one is called eRef about this. So in summary, it is definitely so that in order for neurophysiology to continue to provide a good clinical information, we need to increase our sensitivity, and by quantitation we can obtain that: increased sensitivity, reproducibility, and the transferability between laboratories and from time to time. And the new software and software under development makes it really possible to use it also in a hectic routine. Reference values is the important thing, and they should be obtained exactly in the same way as we are going to use it in routine later. All these values are only numbers. The final interpretation, the integration, is certainly easier if the input data are precise. Thank you very much.
Thank you very much, Erik. The presentation was very clear. We have a couple of minutes for questions. There's one question that I see here. So, how is the sensitivity of Munich's or M-scan methods when a subject has a neuropathy with neurogenic block during early reinnervation? For example, after early phase of trauma, neurogenic reinnervation.
Yes, it's a good question. The block does not influence so much. The more important factor is the total loss of motor units. And the sensitivity is relatively high on the neurogenic side, as I said, but less sensitive on myogenic side. It's very good for timely follow-up of patients, but for detailed diagnosis, the needle EMG is still most important.
Thank you. At the moment, there's no questions here. Maybe if I can ask you, there are a lot of practicing electromyographers listening to talk today. So what do you think, should we use much more quantification in our daily routine? What do you think are the most important things that we miss by doing just the regular qualitative assessment?
This started in the late 1950s, and it has been very slow to be implemented. One of the reasons is that people say, "Oh, I have no time for that in my busy routine." With improved algorithms, with improved electronic possibilities and software, it really doesn't take longer time to make the study quantitative, and certainly therefore more sensitive. For example, a moderate neurogenic one time, is that next time more moderate or less moderate when the patient comes back again? It's important and very good for the patient to that we can produce numeric results of our study, and that is possible nowadays. So we hope that more and more of the methods can be quantitated.
Thank you. So it's just more motivation and effort, and not the technical limitations.
Yes, absolutely. Yeah. And some training in that. And also the crucial may still be the existence of reference values. If you just get a value of 12.5 milliseconds, that doesn't say anything. You must have a good reference material. But the awareness of it and the new techniques to extract reference values will help a lot.
Thank you very much.